I mean, Fred, you basically said it. We don't need psychedelics. If we're talking about, the conversation is moving to talk about love, we don't actually need to talk about psychedelics because it really is sort of a proxy for that. So I'm going to tell you about psychedelics and PTSD in 15 minutes. Everything you need to know. I'm just kidding. But some broad strokes overview. I'm sure most, if not every single person here is well aware of the current of psychedelic research that's happening. So that's what I do. I also work in the psychiatric emergency room, which is where I'm going to go right after this. No disrespect. I have to leave, unfortunately, and miss the rest of the conference. But that's my day job, and the rest of what I do is studying the effects of psychedelics. So I run a clinical trial with psilocybin. We're about to start a study with MDMA. I'm also involved in ketamine research. So when we're talking about psychedelics, different people will define them differently. There's not a universal definition of what a psychedelic is. But psychedelics, first and foremost, elicit a profound change in consciousness, generally more profound than something like alcohol. There's this concept of ego dissolution, which applies more to the classic psychedelics, which I'll talk about in a moment, than MDMA, which is what was researched for PTSD. There's also this feeling of increased connectedness, and often that is experienced as love, either direct love for other human beings or just feeling that one is existing as love or feeling the love in the universe. All of these very deep, profound experiences tend to arise. And last, and I put this last on purpose, is this enriched sensory or phenomenal experience, meaning that the sensorium is heightened. People see things, people tend to see colors much more richly, sometimes actual hallucinations. But this is often not necessarily the therapeutic aspect of psychedelics. It's sort of a sideshow, and I think people often get distracted thinking of psychedelics, calling them hallucinogens, showing people kind of responding to stimuli that aren't there, and that's really not an accurate picture of psychedelics. So I think it gets overemphasized because it is the most visible aspect of psychedelics, but these deeper things are more related to the therapeutic effects. And we're interested in them because it would appear that single doses or only a handful of doses or sessions can lead to these durable changes over time, in contrast to drugs that people have to take every day, some of which were mentioned, like gabapentin. So I apologize, it looks like these got a little bit crunched, but there's two main classes of psychedelics. So one of the tryptamines, those are psilocybin, that's what's found in mushrooms, 5-MeO-DMT, which occurs naturally in a certain toad venom, DMT, dimethyltryptamine, which is in ayahuasca, and then LSD, which is just cut off at the bottom there, which should be there. You're looking at a picture of the LSD molecule. And the tryptamines are related to serotonin more directly than the other class, which are the phenethylamines. Phenethylamines include things like mescaline and MDMA, and there's hundreds of other phenethylamines, and we haven't even begun to study these things. So MDMA is really the only drug in this class, even though there's hundreds, if not thousands, of psychedelic phenethylamines out there that have yet to be studied. So these are the two major classes. What's interesting about researching psychedelics, or just what's interesting about psychedelics as drugs, is that generally when you're doing drug research, you're concerned about physical side effects, medical side effects, things like that. And for most people, not all, but for most people, psychedelics are very safe, even in overdose. All right, and so what you're actually worried about, this slide really got messed up there. Sorry about that. What you're really worried about here with psychedelics is not the medical aspects, but the psychological aspects, okay? And so a lot of things can come up for people that are experienced in their head, but can be quite damaging if not supported correctly. So things like anxiety, panic attacks, dysphoria, paranoia, people can become psychotic. And these can occur across a variety of different modalities. And what we do in the model of psychedelic therapy is we support the individual. This is not a scenario where we're reaching for antipsychotics or Ativan. We work with the person to try to help them make sense of what's going on, or to simply accept it and be curious and be open to what's happening, regardless of whether it's good or bad. So these are not things that we encourage people to go into expecting something great. The best way to go into psychedelics, so we think, is just to be open about whatever may come up, whether it's good or challenging. And in the end, these will lead to insights, so the theory goes. There are some people who probably shouldn't take these, people with bipolar disorder, schizophrenia, primary relatives who have these things. This may increase the risk of something called hallucinogen persisting perceptual disorder, which we saw a lot of back in the 1960s. It's just the clinical term for flashbacks, otherwise called HPPD. So psychedelic-assisted psychotherapy. This is essentially the model that's used in most studies. Sometimes it's called psychedelics with psychological support. It's the same thing. You have two people on either side of the patient. They have some kind of mental health degree, so there's a lot of pharma companies that are doing research. They claim it's not therapy, but they have to be licensed mental health practitioners who are doing this. So I don't know what you call it if you're a therapist sitting in a room with a patient talking for 8 hours on psilocybin, if it's not therapy. Present at all times. And like I said, the idea is that you have a number of preparation sessions to help the person make sense of and to interpret their psychedelic experience with openness and curiosity. Following the psychedelic sessions, there are integration sessions where there's more of the same, a sort of meaning-making process. But this is non-directive. This is not where people are imposing, for example, a psychoanalytical framework on the patient's own experience. It's more, what do you think this meant to you? Why was this important to you? How can you build this insight into your life? And so I like to think of psychedelics not as drugs, really, but they're really more adjuncts to a therapeutic process or to something more akin to practice. They're probably, in the way that they're ultimately going to be seen to work, going to be a lot closer to something like a personal meditation practice or exercise. You were mentioning, how do you run 100 miles? We don't start with 100 miles. And I think people who have a lot of experience with psychedelics will say the same thing. You don't just go as deep as you possibly can the first time, as one example. We know that set and setting is absolutely critical. This makes it so hard to study the supposedly discrete effect of psychedelics, because when you're studying psychedelics, you're not studying the drug effect. You're studying the interaction of the person, what's going on inside their own mind during the entire psychedelic session, what's going on between them and the therapist in the room, what's going on with their interaction with the environment, with the paintings on the wall, all of these things. And so it's very difficult to isolate the drug effect, and yet, as I'll say in a moment, this is what we have to do as part of a clinical trial, and in my opinion is the main reason why MDMA has not yet been approved. So how many people have heard about MDMA being researched for PTSD? There's probably 0 people not raising their hands. This was the first phase 3 clinical trial ever conducted with any psychedelic drug. Published in 2021. In 2023, we saw the second one. And this was using this psychedelic-assisted therapy model that I just described to treat people who had either severe or treatment-resistant PTSD. There was an earlier study that looked only at military veterans and first responders, but for the phase 3 clinical trials, they were looking at all populations who had severe or treatment-resistant PTSD. And this is the trial design. So this thing is not a chromosome here. This is just showing you the different sessions. And I depict this just to illustrate how labor-intensive this stuff actually is and how it's going to be very challenging to put this into a conventional medical clinic. So the orange bands here are the preparation sessions. Those usually last about an hour and a half. The crimson bands, here we are at Harvard, crimson, MDMA, are the MDMA sessions. Those lasted about 8 hours, sometimes longer, up to 10. And then the green bands are the 9 integration sessions. Again, 90 minutes to 2 hours. 2 therapists present for the entire time with all of those sessions. So this is a massive investment of labor up front, assuming that this treatment is actually as good as we think it is. So this is the results of the first phase 3 study. You can see that the blue are the folks, they didn't just get placebo. They got the MDMA-assisted therapy, but placebo-assisted therapy. So they got plenty of psychotherapy, and you can see they did have a little bit of a response. That's a reduction in their PTSD symptoms. The red line, of course, are the folks that got MDMA. And if you look closely, you can see that there's these little red knobs. The first 3 of those are the 3 MDMA sessions. So you can see the PTSD scores dropping pretty significantly. And these were folks who had some pretty severe PTSD. These are pretty impressive results. I'm not showing the second phase 3 clinical trial, but it found very similar results, that MDMA had a very clear separation from placebo with this particular psychotherapy model. These are the 2 studies that went before the FDA last summer. So this was kind of the beginning of the indication that things were not going as planned. This was not the formal rejection. This is the headline from a June Scientific Advisory Committee hearing. So whenever the FDA is going to consider the approval of a new drug, they appoint a committee of people to review the data who are not part of the FDA, and then that committee makes a recommendation whether to approve or reject the application. So this was not the FDA, but this occurred on June 4th of last year. And this panel following, did anybody watch the panel? Did anybody actually watch it? It was an open forum panel, and a lot of, to say dramatic would be a euphemism, but it was quite a circus of critics of these particular clinical trials who had various motivations, I think, in not wanting to see these trials succeed. And unfortunately, at the end of that day, this commission recommended against the approval of MDMA. So that was June 4th, 2024. June 6th, 2024, a Dutch panel that had been doing several months of research on MDMA recommended the exact opposite. They looked at the data and they said, actually, we think that MDMA should be descheduled, it should be decriminalized, and we think that it should be available for PTSD, and we want the Dutch government to start looking at naturalistic use of MDMA for PTSD as part of a study. So not actually setting up a clinical trial, but just observing people using MDMA with therapy for PTSD out in the wilderness, so to speak. Different countries. So in August, this was the final blow for this round, at least, where the FDA itself declined to approve MDMA for PTSD. And I think there was a great deal of disappointment for the field, understandably so. I don't think that this was the right call on the part of the FDA, and there were a lot of problematic issues in the way that they presumably were reasoning about their choice to reject this. But essentially, the battle is far from over. And so what's happening now is there's going to be another clinical trial, and there are a number of other clinical trials that are advancing, not necessarily looking at psychedelic agents for PTSD specifically, but for other conditions that we often see, particularly in military populations, things like anxiety and depression. So what went wrong here? Well, it depends on who you ask. I've alluded to my opinions on some of these issues, but really first and foremost is the bias of our particular regulatory structure. All right, so the Food and Drug Administration is set up by Congress to approve or not allow the use of, in medical scenarios, of drugs, biological products, and medical devices. So they are not set up to evaluate psychotherapy. They can't evaluate psychotherapy. And so what they were looking at in this whole drug application was MDMA, despite the fact that what the clinical trial was of was not MDMA, it was MDMA with therapy. And so there was a lot of confusion on the FDA's part as to how to actually evaluate, was the therapy effective? Was it confounding the results of the clinical study? And I think this shines a light on some contemporary issues in psychiatry more generally, which is that we're very focused on sort of externally visible effects of drugs rather than actually looking at the subjective experience. And so we're much more focused on the what rather than the how. And so anyone who has talked to someone who's been a part of this study, I've talked to a lot of folks who were part of these clinical trials, it's more than just the reduction in PTSD. It's not just the number that their clinician-administered PTSD rating scale went from 100 down to 30. It's more of the qualitative stuff, how that happened, how they actually felt, and how it made a benefit on their lives that I think is lost in the spreadsheets on just the pure data. Right, so back to what I was saying with the role of psychedelic-assisted therapy. Psychedelic-assisted therapy takes for granted that psychedelics are context amplifiers. There's no such thing as what happens to someone if you just give them a psychedelic. If you give somebody a psychedelic with no therapy versus you give them a psychedelic with therapy, if the room is really nice and warm versus a really sterile room with fluorescent lights and drop ceilings like most hospital clinics, these things actually are not just nice things to have. These make or break whether it's a therapeutic experience or a catastrophic experience. And we don't have a way to actually study this from the standpoint of a randomized controlled trial, which seeks to isolate the effects of a drug and essentially presumes underneath it all that no matter what's going on in your life, with your job, with your family, that the effect of a drug is going to be the same. And this is so very far from the case, of course, in anything involving psychiatric suffering, but especially in psychedelics. So I think this is a real challenge that the field is facing. So what needs to change? What the first line says there is that we need, in my opinion, more interdisciplinary input, right? So that Dutch commission that I mentioned had a number of physicians from all sorts of different fields, including emergency medicine. They actually see people coming in with the bad stuff from psychedelics. They had lawyers, they had public health administrators. This was a much more interdisciplinary team than the FDA's advisory committee, which was composed of, I think, 14 or 13 psychiatric researchers and one statistician. No psychotherapists. Nobody on the committee even did psychotherapy. So I think we need to sort of bring in different voices. And another call that the Dutch are leading with is the idea of doing naturalistic studies and actually figuring out a way, how can we bring in data that is not coming out of strict randomized controlled trials, right? And maybe even asking consumers and users, people who are actually going out there and doing this, right? We just write this off as anecdotal information. And on the one hand, we do need to recognize that there is a hierarchy of the quality of evidence. And at the same time, as has been alluded to, there are people going out into the field all over the world and engaging with the therapeutic use of psychedelics. And that is not meaningless data. And I think we need to figure out a way to bring that into the way that we understand how psychedelics are ultimately going to play out in the clinic, even if that's not going to be the sole proprietor of these therapies. I mention this just because the Senate just passed the Halt Fentanyl Act yesterday. Regardless of what one's opinions on the drug war are, there's a provision in this that would make the research far less costly and more easy with Schedule I drugs. And I can say, as someone doing this research, studying a Schedule I agent is insanely time-consuming and cumbersome, and there are so many different federal agencies that you have to deal with. It makes the research very difficult, which biases the playing field in favor of these big pharmaceutical companies rather than the academic medical centers for doing, I think, pragmatic and innovative forms of trials to study this stuff. And I think, on the one hand, I'm certainly very disappointed, like many, that the FDA did not approve MDMA. On the other hand, I don't want to leave the audience with the sense that I think psychedelics are risk-free. I think the psychological risks are substantial. They may be not particularly common, particularly in the hands of someone who knows what they're doing, but they really can leave people with some pretty deep negative experiences, and people can really get opened up and unraveled with these things. So I don't know that we're ready as a society to embrace psychedelic treatments, and this may give us a little bit more time to get a better sense of some of the risks and how this is actually going to play out. Unfortunately, it also means that people are going to continue to suffer and not be able to get treatments, at least here in the United States. So for those that are curious about sort of the more meta, high-level stuff, my group wrote a piece that was published in Nature Mental Health last October, criticizing the FDA decision, articulating some of the vision that we think things need to change in order to take a better look at psychedelics. And then for stuff that's happening totally outside the world of medicine, there are groups that are going down to Mexico and groups that are going to South America. This is a program that aired not too long ago of a number of veterans going down and getting, I think, ibogaine and psilocybin and 5-MeO-DMT. And there's some really powerful stuff in there. And they're not all people that are totally positive on psychedelics. I think it's important to have a multi-dimensional view here. Lastly, this was a study not looking at PTSD specifically. This was a study looking at veterans with traumatic brain injuries using ibogaine, but they did see benefits in depression as well as PTSD scores. Tiny study, but hopefully we'll see more evidence from this group as well. And I'll wrap up. Thanks so much for your time.